Okay. Why don't we get started? I'm sharing my screen. Hopefully everyone can see it. Um, Hi, everybody. My name is Dr. Robby Setton. I am a reproductive endocrinologist and fertility specialist, double board certified. I am a physician at RMA of New York, particularly in Brooklyn. Our practice has offices in Manhattan and in Brooklyn, Westchester, Long Island. I'm one of the Brooklyn physicians. And I'm going to be speaking today about just Fertility 101. I go over sort of broadly, but also in some amount of detail, some basics in terms of fertility, how we think about fertility evaluation, what our options are very broadly as well. And I'm hoping to have some time for Q&A at the end. If there are questions that come up, there's a Q&A box that you'll see at the bottom that you can utilize, and we'll do those things at the end. So without further ado, I am gonna proceed. All right. So firstly, just to give a little bit of context for where we stand in terms of the reproductive landscape. So people don't really realize that it actually is quite difficult to become pregnant. Even in our peak reproductive potential, mid-20s, everything's 100% healthy. Chance of conceiving each month is only about 20%. Um, that being said, most couples end up conceiving within the first 6 months or so of trying. And there's a certain percentage that will conceive in the later 6 months. But once you've reached a threshold of being of about a year of trying, it does give a diagnosis of infertility. Um, Ultimately, we when we have about 1 in 6 couples end up with either infertility or recurrent pregnancy loss, ability to achieve a successful long-term pregnancy, which is a huge number. Um, it affects both men and women equally. And one thing that we'll talk about is that age actually plays a major role in achieving a pregnancy. So this is just some background information. I'll talk a little bit now about natural fertility and how to sort of best maximize your chances of conceiving naturally. And so the fertile window is only 6 days of the menstrual cycle. When we think about the menstrual cycle, we think about it sort of in two parts: is everything before you ovulate and then everything after you ovulate. The fertile window is the day that you ovulate plus the 5 days before that. So it's 6 days in total, roughly. What this chart on the side is showing you are days relative to ovulation, ovulation being right here, and if it's single active intercourse happens within the days prior to that, what the chances are of conceiving. So a single active intercourse and any time during this time can potentially achieve a pregnancy. The closer you are to actual ovulation, the better though. Um, in general, with you can predict when your fertile window is going to be by knowing that ovulation happens and then 14 days later is when your period comes. So if you have a regular 28 days cycle, for example, you know that you're ovulating around cycle day 14 or 15 or so, and so your fertile window will be from cycle day 10 to 14, 15 roughly, with a cycle day 1 being the first day of full flow. Now, in terms of, how best to time intercourse during that time, no one really knows the true answer to that, whether it's intercourse daily during the fertile window, every other day. It really depends on the couple. It's for some couples, it's just not feasible to do with that sort of rigor. But essentially should be equivalent whether it's a daily intercourse or every other day. Certainly we would want at least want a single active intercourse when you're in the latter 3 days of the fertile window. And so obviously this all depend, being able to time this depends on knowing when you ovulate. If you have regular cycles, then it's easier. If you have irregular cycles, it's more challenging. Ovulation predictor kits are very helpful for these sorts of things, but 10% of the population, those kits will not work for. And so sometimes you need a little bit of assistance with this. Now, that's, in terms of a natural fecundability or natural ability to conceive. When we think about then people who have infertility, We define that as inability to conceive regular unprotected intercourse over the course of 1 year. Um, and at which point it certainly warrants doing a fertility evaluation. And I'll spend some time talking about a fertility evaluation and what that means. Now, there are some situations where fertility evaluation should happen sooner than the 1 year mark. If you're over the age of 35, 6 months is when we recommend having an evaluation, or if you have some sort of obvious barrier to conceiving. If your periods are very irregular or you don't get periods at all, by irregular, I mean more than 35 days apart is too long of a period of time. If you have a known condition that affects your uterus or fallopian tubes, a known endometriosis that can impact your fertility, or any known or any genetic conditions can also impact that as well. And so we start the evaluation again after about a year with if you're under the age of 35 or after 6 months if you're over the age of 35. Obviously, other situations in which we do this which is not really the focus for today, will be in same-sex couples as well, or LGBTQIA family building. So I mentioned before that age is a huge factor in terms of reproductive potential. And that's because the quality of eggs changes with time. As women age, the quality of eggs starts to go down more and more. When I say quality of eggs, I mean that when the egg comes forward for the month, there's a higher chance that that egg is not going to be a healthy egg, meaning a genetically healthy egg. And so what we see is that this blue line here showing, or bluish green line, showing percent of maximal fertility being in our 20s, goes down over the course of the early 30s, but then really much more so in the later 30s and then the 40s. Along with that comes a higher rate for miscarriage, because sometimes a genetically unhealthy egg can release, fertilize with a sperm, stick, start to grow, but because it's genetically unhealthy, at some point it stops growing, and that's the most common reason for a miscarriage. And so that's another challenge that we face when we're getting over the age of 35 and into the 40s. In general, there are several causes for infertility. We think about this broadly as about 40% male factor, 40% female factor. Within female factor, we have about 50% tubal dysfunction and 50% ovulatory dysfunction. Estimates about unexplained infertility where everything is okay would be about 10 to 20% sometimes, depending on the study that you look at. But these are the broad categories of infertility. Endometriosis is, I just going to briefly mention, is sort of in its own category or sometimes lumped in with unexplained infertility, condition where the tissue that should be in the lining of the uterus travels outside the uterus. And that causes pelvic pain, pain with intercourse, and it's also an inflammatory state that can cause infertility. It causes dysfunction of hormones, causes distortion of the pelvic anatomy, can impact the quality of eggs, can impact implantation. So endometriosis, which again may be suspected if you have severely painful periods, pain with intercourse. The only way to know for sure is with surgery. But if that is something that is going on, that also can be a barrier to conceiving. So say you've been trying and you're interested in fertility evaluation. The fertility evaluation I'm going to break down for you. It ultimately comes down to three things that you need to have a baby, right? This is the birds and the bees talk, but the doctor version of it. So we need sperm, we need eggs, and we need a uterus with open tubes. That's what we have here. Male factor sperm, ovarian function, that's our eggs, and the anatomy, which is the uterus and tubes. So that's the focal points of the fertility workup. So for eggs, again, we think about it in two ways. There's quality of the eggs, which we spoke about as being directly related to age. Then there's the quantity of eggs that you have. Everyone's born all the eggs that they'll ever have, and they slowly get used up with time. And it's like a bell curve. Most people are somewhere average in the middle, some people on the lower end, some people on the higher end, but where you are on the spectrum, we figure out with what we call egg number testing. So that's this first bullet point here. Day 3 blood work and a transvaginal ultrasound. So there's a couple of things we look at. We do some blood work at the early phase of your menstrual cycle because hormones fluctuate obviously over the course of the menstrual cycle. So we like to capture some hormones in the first couple of days. your FSH hormone, follicle stimulating hormone. It's a hormone made by the brain. And we capture that in the first few days of starting a menstrual cycle, along with your estrogen and LH hormone. And then a hormone called AMH, anti-Mullerian hormone. That's an important one. That one is made by the ovary itself. And again, we measure that as part of blood work. And then we also do a vaginal ultrasound to take a look at the ovaries and count the number of eggs that we're seeing. And that gives us an idea of what's going on in terms of the egg numbers that you have. So that's our egg evaluation. Next, there's the uterus and tubes, which is a test called an HSG. It's an X-ray or a hysterosalpingogram, which is a mouthful. It's an X-ray of the uterus and tubes. And then the sperm evaluation is done with the semen analysis. And I'll show you what those involve. So for the semen analysis, basically we have the male partner provide an ejaculated sample of sperm. We want a sample of sperm that's not too fresh, but not too old. So a number of days of abstinence is going to be between 2 and 5 days. And large number of fertility cases have a male factor or a male factor in combination with a female factor. There's 4 major things that we look at with the semen analysis. One is the volume of the ejaculate. That includes the sperm, but also like the prostatic fluids that come from the prostate and seminal vesicles and things like in different parts of the male reproductive tract. The concentration of actual sperm that we see, we like to see that more than 15 million sperm. How well the sperm is moving, the motility, and the shape of the sperm. Vast majority of sperm in an ejaculate are actually abnormally shaped. This picture all the way to the left is a normal sperm. Our criteria for a normal sperm is that just 4% or more of the sperm is normally shaped. Now, that's how we evaluate the health of the sperm. And there's many different causes that potentially can lead to issues with sperm production that, is multifactorial and beyond the scope here. Next, the last piece, so we spoke about eggs, we spoke about sperm. Last piece is our uterus and tubes. So for the uterus and tubes, we do an X-ray of the uterus and tubes. It's called an HSG. It's done between cycle day 5 to 12 of the menstrual cycle. So basically when you finish bleeding and then within a week, so that's before you ovulate. The way that's done is that a speculum goes into the vagina, similar to starting with a pap smear. And then a radiologist will place a small catheter into the cervix. This here is on an X-ray, this is the vaginal cavity. The cervix is right here. So a catheter goes into here. And then you're sitting under an X-ray machine while this is happening, and fluid is infused into the uterus to fill up the uterus, and we can see the internal anatomy of the uterus to make sure that it's this nice upside down sort of triangle shape that we see here that I'm outlining with my mouse. And we also, to make sure there's nothing structural in there that can get in the way of a pregnancy sticking, like a fibroid or a polyp. We also want to make sure that there's no what's called congenital anomalies, meaning something that you're born with, say a septum, like a division within the uterus, or a double uterus, or some other sort of like abnormality in the shape of the uterus that can get in the way of pregnancy. And then the fluid that continues and should fill up the fallopian tubes that come out. And when we see fluid come out, that's when we know that the tubes are physically open. Sometimes can identify a blockage in the tube, which is obviously a cause for infertility. Also can identify significant fluid buildup in the tube, which can lead to not just infertility, but also pregnancy loss as well. And so that's how we evaluate the uterus and tubes. Now, once we do the evaluation, we identify what should we be targeting? Is there an issue at the level of our eggs, of our sperm, of our uterus and tubes, or is everything looking okay on paper? And then we decide what our approach should be for treatment options. Goal is always to try to help couples conceive in the next in the most low-tech way possible. But we also have to try to get you to your goal. And so it's always a matter of weighing risks and benefits of each different type of approach that we have. In general, there are a couple of different broad strategies that we have. One is called ovulation induction, which is we use it for someone who has dysfunction of their ovulation. So we give them medication, usually pills, for a couple of days that can help with growing an egg. Another is a strategy called superovulation, where our goal is not for you to release one egg, but actually to release multiple eggs, maybe. This is a strategy that we often use with cases of unexplained infertility or for other indications as well, depending on your age and the overall picture. We often can couple that with ovulation induction or superovulation with either timed intercourse, so we get eggs to grow and then you have intercourse, or we can do an IUI, an intrauterine insemination, where basically at the time that you're ovulating, we can get a sample of sperm, process it in the lab, and then take that sperm and put it directly into the uterus. So we get a good amount of good quality sperm close to the eggs at the time that the eggs are releasing. The big gun that we have, ART, assisted reproductive technology, is IVF, which we'll talk about as well. So to get a little bit more granular or to get a better sort of grasp of what's involved in ovulation induction or superovulation, those first two options with an IUI, the way that typically goes is like this. Cycle day, CD1, cycle day 1, you get your period, you give us a call. Then we have you come in within the first couple of days, and we do blood work to see where your hormone levels are to make sure that things are hormonally appropriate, because the pills that we give you influence your hormones. Then we can typically give you 5 days of a pill called Clomid or letrozole. Those are our two most common medications that we give. And then a few days after you finish that, taking that for 5 days, you come in and we do an ultrasound. And then we see how many eggs have grown, or does it look like your body is ready? And if you're ready, we do a one-time injection called a trigger shot. That basically causes your eggs to release in a timely way. And then again, we either have intercourse or we do an IUI, intrauterine insemination. IUI is where we get the sperm, we put it into a small syringe with a catheter, and we place that catheter into the uterus and release the sperm into the uterus. Idea is that with regular intercourse, sperm is deposited in the vagina all the way down here. But and they have a long, long way to traverse in order to be able to meet up with the egg that's being released. They meet up in the fallopian tube on either side, whichever side the egg is being released. When we get the sperm into the uterus, it's more eggs at the time that the action is happening. 2 weeks later, we see if you're pregnant or not. That's our low-tech approach. Our high-tech approach is IVF. And I'll spend a few minutes talking about what's involved in IVF very broadly. So there are many reasons why you may need IVF. If you failed low-tech approaches, and then it depends on other factors such as your age, what the exact diagnosis is that you have. There are some reasons where we have to go straight to IVF. So for example, if you have a blockage in both of your fallopian tubes, there's no way for sperm and egg to naturally meet up. And IUI doesn't help because that depends on sperm and egg naturally meeting up in the body. And so we have to bypass the tubes in those sorts of cases, which would mean IVF. Sometimes a male factor can be mild and amenable to an IUI, to intrauterine insemination. Sometimes the male factor is very severe, and we're not going to be able to achieve fertilization and pregnancy with a low-tech thing. We have to get individual sperm and physically connect it with the eggs in the lab, and other reasons that we may need to do so. So the main conceptual difference between IVF, in vitro fertilization, and in vivo fertilization. In vivo means within the body. Fertilization, meaning the joining of the sperm and the egg, happens within the body. The typical site for that is in the fallopian tube, as you can see here on the left. Egg is released and sperm and egg come together. In vitro fertilization, the eggs are extracted and the fertilization process happens in the lab, in the dish. So eggs are extracted, they're put into a dish with the sperm, they're joined together, they're incubated or cultured and grown out to embryos, and then that embryo is put back into the uterus. So it bypasses the tubes in that situation. To do IVF, there's essentially a lot of background testing that we have to do to make sure that you're an appropriate candidate for it. And then there are certain phases of the IVF cycle that I'll go through, all these different phases that we do. There's different types of protocols that your physician may choose. There's different types of medication injections. that we can use. All these things are done in order to optimize your outcome from a cycle, and everything is always personalized. The basic concept of what we're doing is that your body is the hormone injections that you do with IVF is follicle stimulating hormone, FSH, same exact hormone that your body naturally makes. Your body only naturally makes, and it's that same hormone actually I mentioned that we're checking in your blood in the first couple of days of your cycle. Your body only makes enough of this though to get one egg to grow a month. So your FSH hormone that your body releases acts on your ovaries to grow one egg. What happens in nature is that your ovary brings forward a certain number of eggs every single month. So say that there's 10 eggs, for example, that the body is trying to bring forward. Your body will naturally choose one of those that grows, releases, ovulates. The other 9 that came out will die off. So what we try to do with IVF with these hormone injections is we're just exposing your body to that same exact hormone at a higher level. So it's exposing the body to more FSH in the hope that we can maybe save those other 9 eggs from growing. We can get those other 9 eggs to grow and hopefully avoid them from being wasted that month. We're not taking away from your future eggs. We're not causing early menopause or anything like that. We're just trying to salvage whatever the body would have used up that month. And so you may hear a lot of variability of people going through cycles and saying, I got this many eggs, I got that many eggs. It really is dependent on how much their ovarian reserve is, how many eggs their body is bringing forward, and also how their body responds to the medication, which can be very variable. And that's where these different protocols come into play. So what ends up happening is you're doing the hormone injections, these daily injections, little tiny needles go into the belly, you barely feel it going in. And we then bring you in over the course of about 2 weeks is the amount of time it takes. And we do monitoring appointments where we're monitoring your response to the medication so we can make adjustments on it to make sure that things are going appropriately. And when you do the monitoring appointments, we do ultrasounds and we see these black circles here that I'm highlighting here at the top part of the screen. Those are what are called follicles. These are basically the sacs that have the egg inside. And so that's what we're trying to get to grow. We're trying to get all of these to grow, as many as we can. When it comes time for that, your body is ready, we do one last injection called a trigger shot, and that causes the final maturation process of the egg. Then we time it so that 36 hours later, or so a day and a half later, we're doing the extraction of the eggs. It's called the egg retrieval. The egg retrieval, it's a procedure under anesthesia. So you're asleep, you don't feel pain, you won't remember it. A needle goes through the vaginal wall. This is the needle over here, into the follicle, into the ovary. And it basically drains this black circle. This is all fluid. And within this fluid is the egg. And so we drain that fluid and collapse it. And then we pass the fluid over to an embryologist. And they look under the microscope to try to find an egg. This is a mature egg. Once they get the eggs, they have to join them with sperm. There's different ways we can do that. One is called conventional insemination, where we take the egg and we just put it with the sperm in the dish. So you might see that compared to this here, we have all these little dots around the egg over here. All these little things, little dots with if you look closely, you see these little strands. These are all sperm that are trying to get into this one egg. This is called conventional insemination. Sperm and egg are in the dish trying to do their thing. In some situations, we have to help out fertilizations. So that for that, we do something called intracytoplasmic sperm injection, or ICSI. Sorry, this should say ICSI, not IUI. We do this when there's a more significant male factor, when the sperm is not of good quality, or if there has been a poor clinical history in terms of fertilization. The way that's done is that the embryologist takes one individual sperm, and that's this under this microscopic needle. So this is a needle. This is the egg. It's being held by one pipette under a microscope. And then there's another needle right here under the microscope. And this little black towards the end of it, this little dark circle right here, that's the sperm. And so they insert through this needle, they puncture open with a little tiny slit, the egg, and deposit the sperm into the egg. And that's called ICSI. That's how we help out in situations where the sperm and egg aren't able to naturally meet up or do it on their own. Once the sperm and egg forms together, we incubate it for 16 hours to 18 hours, and we look to see if fertilization happened. And the sign that that happened is when we see these two sort of like bubbles in the middle. This is the DNA from the egg and the DNA from the sperm. And they're starting the process of joining together, creating an embryo, a new life. The the embryo then has to divide several times. So first it splits into 2 cells, then it divides in half and divides into 4 cells. You see 1, 2, 3, 4, divides into 8, and then continues to develop. And we hope that over the course of 5, 6, 7 days, we can form what's called a blastocyst. This is the name that we have for a fully developed embryo, and this is what gets put back into the body. There's 2 parts to this embryo. There's this dense sort of ball here. This is the part that becomes the baby. And then there's this whole ring over here. This is the part that becomes the placenta. There are some other techniques that are sometimes used in the lab. One is called assisted hatching. So basically the egg embryo is in sort of like a shell, and sometimes we have to help it break out of the shell. There are some clinical indications in which we do this. The way that's done is that a little slit is made in there's like a halo you can see around, I think clearly on this one. There's like halo around here, and then there's a slit that can be made right in that barrier to allow it to hatch out. Another option that we have is something called PGT, pre-implantation genetic testing. So this is basically something that we do when we have a blastocyst. Instead of taking that embryo and putting it into the uterus immediately, we can do a biopsy of the uterus, of the embryo, to test the embryo to see if it's a healthy embryo. There are several forms that this takes that this can be in. One is PGT-A, so pre-implantation genetic testing for aneuploid. That just basically counts the number of chromosomes to make sure that the embryo has the correct amount of DNA, which is the most common reason for miscarriages and things like that. And so that can help potentially optimize your success, depending on your clinical circumstance. Another is PGT-M, looking for a monogenic disease, which means that, say, you and your reproductive partner are both carriers for a same genetic condition. We can test the embryo and have a risk of having a kid affected by a certain condition like Tay-Sachs or cystic fibrosis or sickle cell or whatever it may be. We can test the embryo to make sure that it's a healthy child. So that's another test we can do. There's also things we can look for what are called translocations and also for HLA matches. So this is something where, say, you have another child that has a disease that needs a bone marrow transplant and they need a match and whatnot. When you're having the next kid, we potentially can match the blood type and whatnot to that child, and we're able to use cord blood from the delivery or the placenta after the time of delivery to help with treatment for the sick sibling. The way that this is done is, so with the way we do the PGT, the biopsy of the embryos, is that under a microscope, again, we have a holder, and this is our embryo that's fully expanded. And basically a few cells are taken off, about 5 cells or so are taken off from the part that becomes the placenta, and then the embryo is frozen while we wait for the results of that genetic testing, so we can see if that tests the health of the embryo. The embryo transfer, then, how do we get the embryo back in? So we prepare the body, and in the right window, this is an ultrasound, this is the bladder here, this down here is the uterus, and this is the lining of the uterus. This is where we're placing the embryo right in the middle of that, and this brighter line is a catheter going in. And it's really just like the embryo transfer, embryo going in is like a fancy pap smear. There's no anesthesia or anything like that. This just sort of gives like an overview of what we were talking about, of how there's about 2 weeks of gonadotropins, which is the hormone injections, 2 or 3 a day, HCG, which is our trigger shot, ER, which is the egg retrieval, and then the embryo transfer. We always give some progesterone supplementation when we're doing these sorts of things to help support early pregnancy. In situations where we're testing the embryo, we again have our injections for 2 weeks, the trigger, the egg retrieval. Then we grow the embryo out and do a biopsy and freeze. And then we have to wait until you get the period. We wait for the results. And then we give you estrogen and progesterone pills and then pill injection. And then do the embryo transfer the following month. A lot of information I just went through. We'll open for questions now. Stop here. And we'll go to okay. So, and that's before getting into that, just want to say again for anyone that may have popped in late, Dr. Robby Setton, and I'm a fertility specialist at RMA in Brooklyn, part of a larger RMA of New York, with practices again in Brooklyn and New York City, Westchester, and Long Island. And happy to answer any questions that anybody may have. And again, happy to provide you guys with our information if anybody would like, in order to set up an appointment to find out more about your own reproductive potential. Okay. So I'm not seeing any questions. Oh, we do have questions. There we go. So the question is, which has better fertilization rates, ICSI or traditional insemination? It's a good question. It depends on the semen analysis and clinical history as well. So in a situation where there's a normal semen analysis, and there's no other huge significant egg factors such as advanced age, there's there's prior proven paternity as well from the sperm contributor. There's equivalent fertilization rates with ICSI and conventional insemination. In situations with no prior proven paternity, meaning the male has never fathered a pregnancy in the past, whether it resulted in a baby, miscarriage, abortion, whatever it may be, there is about a 5% chance of fertilization failure with traditional or conventional insemination. That goes away with ICSI. Nothing ever 100%, but essentially does. And in general, though, ICSI does have a generally slightly higher fertilization rates, but live birth rates end up being equivalent, again, depending on the clinical context. I'm gonna this one. Okay. Next question, is there a reason why egg quality is poor and how can this be mitigated? This is a great question. So what happens, so we were speaking a lot about how quality of eggs changes as time goes on. So as we age, our bodies become less efficient at all the processes it needs to do. And then we see this in every organ system, right? As we get older, our knees are hurting a little more. Our muscle recovery is not as good. Our cardiovascular system is compromised. People develop blood pressure. They develop thyroid dysfunction. People develop medical issues as they age. Particularly though with the eggs. So the eggs, again, you're born all the eggs that you'll ever have, and they lay dormant within the ovary. And then when the body works on trying to bring these eggs forward, bringing a certain number of eggs forward, and as they come forward, these dormant eggs need to mature, they need to grow, and then they need to split their DNA because they're arrested in a certain division in a certain process where they still have two sets of DNA, right? Because everyone is made of two sets of DNA, but in order for there to be an egg or for there to be a sperm, that DNA has to split in half. So when the egg is coming forward and and it's splitting in half to present itself to be one of the 10 eggs that are candidates for the month, the body just becomes less efficient at that process and is more prone to errors in splitting the DNA. And so, as opposed to when you're, say, 25 years old, 75% of the time you have, when an egg comes forward, it's going to split evenly 50-50. Half the DNA is going to go out, and we're going to have correct amount of DNA in the egg. But when you're 40, only a third of the eggs that are coming forward are going to split appropriately. Many of them will end up giving extra, erroneously give an extra DNA or piece of DNA and whatnot. And so this is just nature. And there's not really much that can be done to avoid that sort of natural process. There are some things that can be done, though, to try to enhance your environment. So, for example, there are some things that are known to make this process worse, such as excessive drinking, any sort of inhaled smoke. There's some thought out there about exposure to like certain types of plastics and different things that might be sort of environmental exposures, nonstick pots and things like that. There are certain supplements out there. You may read a lot about them on the internet. CoQ10, COQ, and the number 10, and vitamin D are helpful for quality of eggs. The amount that it moves the needle is a small amount, but it is there. The other things that you may read about, the data isn't really behind. Next question. Can you do anything to make your life cycles less than 40 days? What will that affect? So it's a question about long cycles, and is there anything that can be done to make the cycle shorter? And would that affect IVF results? So there are several. So whenever a cycle is more than 35 days long, it suggests that there's some sort of dysfunction of ovulation. It could be due to many different things. PCOS is one, which is a hormone imbalance. It could be from prolactin hormone, an excessive amount of that. It could be from thyroid dysfunction. It could be from something called congenital adrenal hyperplasia. There's several things. It could be also from a severe diminished ovarian reserve from having very low egg numbers. So there's many different reasons as to why cycles may be long and why there may be ovulation dysfunction. Ultimately, targeting that specific thing that is causing the ovulation dysfunction and the long cycles can help reduce your cycles to a more average length. The impact that it may have if, say, you have long cycles and you want to do IVF is it really, unless there's something that's inherently with the egg numbers, it shouldn't impact your outcomes with IVF. Next question. When would you recommend moving from retrievals to donor egg? Is it a number of failed cycles or age? It's a good question. So this is something that's always personalized. The number of retrievals of IVF retrievals before we say it's time to move on to donor egg, again, it's something that has to be personalized. In general, if it's thinking very broadly, there are certain situations where donor egg is certainly warranted. I'll get to that in a moment. But from a, trying with your own eggs perspective, within doing 6 cycles of IVF, the way we think about that is that we know up to 6 cycles of IVF, there's no long-term health risks. Beyond that, we don't know as much. And so that always, for me, is a discussion time to see, what are we achieving with our IVF cycles? Are we creating embryos? Are we not fertilizing? Are we not, what are the milestones that we're not being able to hit? And what is the reason for that? If it's something that we think can overcome by optimizing protocols and whatnot, then we can keep going. But we have to just recognize that there could be potential long-term effects on the health of the ovaries later on, borderline tumors or whatnot, things that we don't really know as well about. So it's always a conversation about risk-benefit ratios. In terms of age, the donor egg. So every center has sort of different cutoffs that they use or different criteria that they use. In autologous IVF, I think being age 45 or above is certainly a first-line indication for donor egg. In situations where we stimulate people who are 45, 46, 47, I would say I mean, 99% of the time, because we can never say absolute, where it's bad news. Um, the quality of the eggs just becomes just too compromised that our tools just don't work well enough in that sort of scenario. And so donor egg is really the best option in those cases. There are some situations where donor egg is needed earlier, in the earlier part of the 40s. You did a number of cycles and you fail, and so it doesn't mean you have to wait till 45. You could be doing this at 41 or 40. There are also situations where you may be 30 years old and you go through early menopause. In those and you're out of eggs. If you're out of eggs, at an early age, premature ovarian failure, that would be another reason to do donor egg. There's several different potential reasons why you may do that. Any other question? Okay. All right. Well, it was a pleasure speaking with everyone here. And I hope that that you found this information helpful. Again, if you'd like to schedule an appointment with either myself or one of the other physicians at our practice, you can reach out 212-756-5777, or check out our website as well. Have a good night, everybody.